So to go for a anesthesia for or understanding a patient with obesity, we need to assess uh, the risk, and we have to assess the patient physical condition. So we have to assess the comorbidities like hyperglycemia or diabetes and hyperlipidemia, hypertension, and presence or absence of coronary artery disease. Other respiratory problems, assessment by lung function test and other thing, and liver disease by scanning, and OSA. We'll discuss detail in OSA section. Evaluation of medical reasons of obesity, if those who what can be treated. Some facts here: endocrine disorders other than diabetes mellitus is 47% more in obese patient. Hypothyroid is more in 18%, and pituitary is almost 2%, and Cushing's is 15%. These are chart of the routine pre-op tests commonly advised for assessing obese patient. Look, there is testosterone and polysomnography, vitamin D, other things is common. Status post bariatric surgery patients are, if they come for redo surgery or some other reason for surgery, they have a 6-monthly follow-up, and they need to evaluate a lot of things because of the altered physiology. There's a lot of macro and vitamin deficiency, macronutrient deficiency. Some of the drugs that may affect anesthetic factors are commonly that patients are taking is metformin. Only that do not have any effect on the kind of anesthetic risk. But early start that's available here, those patients are having repeated diarrhea or loose motion kind of thing, malabsorption thing. So they will have electrolyte imbalance and fast soluble vitamin deficiency. And some herbal low fat wet loose centers, they will use diuretics routinely, so that may lead to hypovolemia, hyperkalemia. We have to be careful. And other drugs has some effect, mostly on the cardiac systems. So airway is the most important thing to deal with obese patient. We have to thoroughly assess airway anatomy. And the next thing we would like to do is just basic thing is the room air saturation and desaturation on activity. That we can ask for a 6-minute walk to see how the patient's saturation goes down, and how the patient's saturation goes down when the patient is in a supine position. So these will give you a indication of the severity of the respiratory problem. And the patient may be falling asleep when in the PAC clinic. Then those patients may be having history of smoking, or maybe asthma, or maybe COPD, so they need to be evaluated. For echo, will give you an idea about the pulmonary hypertension. Usually 40 or 45 is the limit. Beyond that, we need some interventions with drugs, and if it is OSA, CPAP or BiPAP therapy may, for at least 6 weeks, may reduce this pulmonary hypertension. DVT predisposition, we have to evaluate, because this is the single most reason for perioperative death, pulmonary embolism, and DVT is a consequence of DVT. The patient need to be ambulated immediately after surgery. That's why in PAC we have to teach the patients breathing exercises and the importance of teaching session for early ambulation and mobilization. Now again, as I said, I will be discussing some detail about obstructive sleep apnea and obesity hyperventilation syndrome. With 2 index of rise in BMI, there is 4-fold rise in obstructive sleep apnea. So the prevalence, I don't know which data, maybe international or US data. In female, it is normal weight, it is 2%, and male 4% only. But when it is morbid obesity, it may rise to 25% of the population, and in male, it goes up to 74 or 78%. So other factors that needs to be other than BMI is the neck diameter and daytime ABG and room air. So sleep, nighttime nocturnal hypercarbia may be present for some other reason, but daytime room air ABG is required. And for the lung function test, although there is not much of correlation with the OSA with the lung function test, but they are done. OSA, they are prone to a depressive effect of hypnotics and opiates, so we have to be careful about them. OSA complicates mass ventilation, that we will see later on. The polysomnography is the gold test for detecting OSA. Is usually a 7-hour sleep test. If there is more than 5 apneic events per hour, that means for more than 10 seconds there is interruption of airflow, or more than 15 hypoapneic events per hour, when the reduction of airflow 50% for 10 seconds. These are the criteria for OSA diagnosis, and there may be AHI apnea index that is called apneic hypopneic index ratio. Actually, that is a good guide of severity of the OSA. We can take history from the partner about the snoring. There may be interruption of breathing or wheezy breathing, nasal breathing, making a lot of noises, and decreased daytime performance, morning headache, and irritability. As I said about neck dia, 40 to 42 centimeter at the cricoid level. There may be daytime somnolence, and usually malampati would be 3 or 4. There may be hypopnathia, short thyromental distance. So for these patients, evaluation of the airway with a direct laryngoscopy and imaging study is may be necessary if airway intubation may be considered. The therapeutic aspect is we can give CPAP or bilevel PAP to give relief to this patient, and we have to know what is the setting of their CPAP BiPAP patient, because immediately after postoperative we have to give that we have to set the machine to that setting. And for deleterious effect of the OSA, those patients who are not yet introduced with CPAP or BiPAP machine, they may need to few weeks of CPAP or BiPAP therapy. Obesity hyperventilation syndrome, on the other hand, is a chronic daytime hypoxemia, PO2, 65 millimeter of mercury. Pulse oximeter can detect this. And there is permanent hypercapnia, PCO2 more than 45 millimeter in the absence of COPD. That is pathognomonic. And BMI usually more than 40. Majority of the OHS has OSA. And you know about PQCAN. PQCAN is the severe end of the obesity hyperventilation syndrome with core pulmonary features. Difficulty of diagnosis and differential diagnosis should be for obesity with COPD, obesity and pulmonary hypertension and right ventricular hypertrophy and right ventricular failure. These are the patient will present with a difficulty in distinguishing. Perioperative optimization and postoperative care to be uh, specially taken care of, because these are the increased mortality and morbidity, and they are high increased mortality and morbidity. This is a slide about some medical impairment associated with obesity hyperventilation syndrome. There may be CNS like cognitive deficit, memory loss, and decreased neuronal drive, and upper airway obstructive sleep apnea and increased intubation risk, respiratory restrictive lung function, pulmonary hypertension, hypercapnia, hypoxia, metabolic central obesity and metabolic syndrome or syndrome X, what they call. There may be a chronic inflammatory stage, chronic inflammatory situation in the body, and insulin-like growth factors deficit may be there. Cardiovascular, there may be endothelial dysfunction and leading to coronary artery disease and other chronic heart failure. Endothelial dysfunction may lead to both MI and also deep vein thrombosis kind of thing. And in general, there may be some peripheral edema from cardiovascular failure or increased morbidity, mortality, and decreased physical activity. This is a overall slide. What happens with the sleep apnea, obesity? There may be hypoxia, acidosis. There may be pulmonary hypertension. On the other hand, with obesity, there is need for increased tissue to supply. So there is increased cardiac output, and those cardiac output initially will be accommodated higher volume with little dilatation, giving rise to some hypertension, and ultimately left ventricle will be stressed and giving rise to left ventricular hypertrophy or eccentric hypertrophy or cardiomyopathy, and ultimately left ventricular failure. So ultimately both will sequentially give rise to biventricular failure. Regarding cardiac assessment, I have given stress on the venous aspect, venous prevention or assessment of the venous aspect more, because this is the major cause of death in obese patient. So we have to know the patient's exercise status. Some of them can go for treadmill, but many of them will not be able to. There is a reclining cycle which they can do, or for those who are not able to do that, even there may be dobutamine stress test can be done. For treatment, low molecular weight, a patient may be getting low molecular weight or preoperative aspirin, or some of them may be having warfarin also. We have to check for the signs and symptoms of venous disease and absence of evidence of venous disease by DVT exclusion by sonological study. Patient should be in optimal hydration condition. Early ambulation and motivation we have discussed before already. So other cardiovascular assessment, we have to, in the checkup, we have to see the size of the cuff or appropriate size of the cuff is possible. Wrist BP, it may read 5 millimeter of mercury less than arm BP, but over the period of time, it will give you a trend. So we are using practically wrist BP most of the times. A peripheral venous line, you have to do at least 2 venous lines. So you have to look for the peripheral adequacy of peripheral venous line. For some of the patient in over the chest. There is a unusual subcutaneous vein that flushes up in obese patient that may be used in case there is no peripheral vein, or ultrasound machine can be used. A-line, usually we are not doing A-line for bariatric surgery, but those patients with needing ABG sampling, A-line is given. This is accurate and continuous tracing of blood pressure. We have to assess the cardiac reserve, assessing ECG, echo, to rule out hypertrophy or extent of hypertrophy, rule out ischemia and conduction defect and pulmonary hypertension. To look for the possible CVP line if it is necessary. Usually ultrasound is used, but routinely not done. T to assess central volume rather than CVP. CVP can be misguiding. So with TEE, even after induction, can assess the volume status. Some risk factors predicting perioperative cardiovascular morbidity is high-risk surgeries like emergent and major thoracic abdominal vascular surgery, history of CAD, congestive heart failure, or cerebrovascular disease, pre-op insulin, and plasma creatinine of more than 2 milligram per deciliter. Metabolic assessment, especially diabetes mellitus, we have to know the exercise capability and dietary behavior. It is found that 5 to 10 kg loss, if can be achieved by 20% decrease in calorie intake, plus 30-minute physical activity, the fasting glucose is usually normalized. Some patients are taking sulfonylureas, which are longer acting, more than 24 hours. If sugar goes below 14 millimoles per deciliter, the phagocytic function improves and intracellular killing capacity, T cell function, those becomes normal. So it's not necessary to go for tight control in obese patient, because hypoglycemia would be a real danger to face. And if the patients are getting insulin any kind, it's better to switch over to soluble insulin. The other thing is, because of the malnutrition, patient do not take, there may be hypocalcemia, so calcium had to be supplemented, which leads to improvement in hypertension and eating behavior disorders. Hyper and hypolipidemia, some of the drugs cause myopathy, and nicotine is important because nicotine causes peripheral vasodilatation that has to be discontinued on the OT day. Because of the hypolipidemia, there may be some neuropathy, anemia, and for correction of that nutritional deficit, and also to change to induce some weight loss, especially reduce the size of the liver. Beginning before 2 weeks or 3 weeks before surgery, they're using high protein and glucose solution that may give rise to some renal problem. Last but not the least, probably psychological assessment. So patient emotional stability and increase awareness about the health benefits of losing weight. They had to be strong-minded, and that can be reflected in the diet diary, that what they are maintaining, and the positive attitude. The failures are, if the patient is drug abuser, major untreated psychiatric disorders, and compulsive eating behaviors, and chronic fatigue syndrome, lethargic, sitting and eating only. Musculoskeletal system assessment, because the patient might have some osteoarthritic change. So during the positioning, we have to assess if the limbs can be extended or can be, say, right angle properly. There may be some stiff shoulder or neck movement, mobility is not there. So we have to assess all these things because neurological injury is a um, rather worrisome thing. An obese patient it is usually with more than 38 BMI, it is about 29% than normal weight patient. Overall risk classification, the ASA classification is the generalized classification with between BMI 30 and 40, it automatically falls in ASA 2, and more than 40 is a 3, so it has corresponding death rate. But this is the other risk mortality, obesity surgery mortality risk scoring is validated in 4,000 patient study. As you see, the BMI more than 50, male, hypertension, pulmonary embolic risk, and age more than 45 years. These are the 1 points. So if it is more than 4, the mortality is 2.5 or something. So as we prepare the patient for surgery, the first thing to look for is aspiration prophylaxis. The obese patient, although the present recent studies do not say obesity as such is not a high risk for aspiration, unless there is some other factors. Standard preoperative fasting guidelines for patient without risk factors, but those for going for gastric surgery, usually is a 12-hour fasting is recommended. Risk factors, as I mentioned, about the gastroesophageal disease, gastroparesis, and bowel obstructions. Both liquids and solids are not delayed as such in obese patient. American Society of Anesthesiology do not recommend routine medication to decrease aspiration risk in without risk aspiration patient. Gastric ultrasound can be used to assess gastric volume correlated to the volume of gastric aspirate in obese patient to assess finally that the stomach is empty. If sedatives are required, it should be very low incremental titrated to effect to allow some anxiolysis just before transfer of the patient.